Introduce Zach Milestone. He is one of our research assistants in the Department of Trauma and Burn Surgery, and he's going to share with you some of our current research efforts in trauma at CNMC. And feel free to use the chat to ask questions. And that's it. Take it away, Zach.
Cool. Thank you, Cindy. Hi, everyone. I'm Zach. I conduct research here at Children's National in Trauma, and I work under the guidance of Dr. Burke. My goals for this presentation is to tell you about some of the research projects that the department's currently working on and try to explain how they can impact patient care. So just for a little background, I'm sure you've all heard this at some point today, but trauma is the leading cause of preventable death in children. 4% of patients treated as trauma activations nationwide don't survive until discharge. And of these deaths, 1/4 can be classified as preventable, with about half relating to errors that occur during the initial trauma resuscitation. We can classify these errors into 3 basic buckets. They're knowledge-based errors that occur when a provider has incomplete or incorrect knowledge. There's skill-based errors that occur when a provider fails to correctly execute a procedure. However, up to 85% of the errors contributing to preventable deaths in injured patients can be classified as rule-based errors. These occur when providers fail to follow established protocols. So how can we work to prevent these errors? We've already discovered that most of these errors are due to deviations from the established protocol rather than a lack of skill or knowledge. So creating additional guidelines and algorithms won't do much to improve patient outcomes. Healthcare providers need to work smarter, not harder. So our work is primarily aimed at creating decision support tools. The first project I want to discuss is a recently submitted paper entitled Reducing the Time to Blood Administration After Pediatric Injury, a Quality Improvement Initiative. Here we chose to focus our efforts on decreasing the time it takes to begin blood transfusions. Hemorrhage is the leading cause of preventable death in children, so it's incredibly important to recognize and treat hemorrhagic shock as early as possible. We began our efforts to reduce the time to blood by conducting an extensive video review of the trauma resuscitations who received blood in the emergency department. And we identified 3 activities associated with delays in the time to blood. The first was the physical location of the blood products. The second was the establishment of intravenous access. And the third and most common type of delay was associated with the use of the level 1 rapid infuser. To address the first, we wanted to increase the accessibility of blood products. So in August of 2019, we purchased a blood refrigerator for our code room. Prior to this, blood products were retrieved from the blood bank upon request. To address the second intervention was created, we created an IV access algorithm with a multidisciplinary team. The algorithm aimed to reduce the time to IV placement and increase awareness of barriers to rapid access, and to define when to establish an IV versus intraosseous access. The algorithm was distributed to staff in June of 2020. Finally, to target delays associated with the use of the rapid infuser, we created a new nursing educator position in September of 2020. The responsibilities of this role included debriefing nursing staff following resuscitation and coaching nurses through the use of the rapid infuser. To evaluate the impact of these interventions, we reviewed electronic health records of all of our trauma patients who received blood products in the code room from January of 2015 to June of 2021 to obtain the time to blood transfusion. We found that before the implementation of any intervention, there was a median time to transfusion of 26 minutes. After we purchased the blood refrigerator, there was a significant and a sustained decrease drop down 12 minutes in the observed time to blood administration. Interestingly, the addition of the IV algorithm and the nurse educator role both had no effect on the time to blood. Both of these interventions were educational initiatives and are optimal tools to use when knowledge gaps exist. There are several reasons that these initiatives may not have had any impact on the reduction of time, including the motor delivery, and the additional workload proposed by the intervention. Project designs like these education initiatives increase the bedside provider's complexity of work and add additional workload onto their already busy environment and are ultimately unsustainable. Therefore, to further improve our time to blood administration, we want to focus our efforts on improving the availability of information, assets, and resources to create sustainable improvement. The next project I want to discuss is also focused on decreasing the time to blood transfusion, but rather than focusing solely on what's occurring in the code room, we wanted to improve the information available to providers to help them more quickly and confidently identify patients in hemorrhagic shock. Early stages of hemorrhagic shock can be difficult to recognize, and particularly difficult to recognize in children. Kids can lose up to 40% of their total blood volume without any significant changes in vital sign. People have tried to make formulas to better predict hemorrhagic shock using early vital signs and other quickly obtainable clinical information. There's the shock index, pediatric age adjusted, or SEPA, which uses the patient's heart rate, systolic blood pressure, and adjusts for their age to identify high-risk patients. Besides SEPA, there's also SEPA-B, PSI, RSIG, which all use more complex formulas and may include a patient's GCS to better identify children in compensated hemorrhagic shock. We wanted to create a similar tool to predict hemorrhagic shock, but a tool that takes advantage of all of the pre-hospital information available to us, such as mechanism and CPR occurring in the field. With SEPA or any of the other predictors I just mentioned, if you don't know one piece of information, in the case of SEPA, that'd be heart rate or blood pressure, the tool becomes useless. We wanted to create a tool that can still make a prediction even without all the possible information. And finally, we wanted to create something that could be updated with information from the emergency department. As this information becomes available, we want to update and improve our prediction. With all of these functions in mind, we chose to begin working on a type of probability network called a Bayesian network. Bayesian networks allow the user to input a variety of variables. In this example here, there's sprinkler and rain. And then it outputs the probability of some event occurring. So here we get the probability of the grass being wet. To develop our model, we needed to use an incredibly large data set of patients. So we decided to pull data from the National Trauma Data Registry for years 2017 through 2019. This is all traumas nationwide for trauma centers that choose to give their data to the data bank, and included over 350,000 patients. It's worth noting that due to the limitations of the data set, our outcome variable for this network is the probability of a patient needing a blood transfusion in the first 4 hours, rather than a blood transfusion in the emergency department, which would have been ideal. We needed to decide what variables would be helpful and what variables would be available to providers. And ultimately, we chose to include the following. We have age, mechanism of injury, pre-hospital and ED vital signs, including heart rate, blood pressure, pulse oximetry, GCS, and the emergency department temperature. We also were able to include the injured body region and whether CPR was performed in the field. To decide how these variables interact with each other and how best to structure our network, we opted to use the data-driven approach rather than solely clinical judgment. So we inputted our data into a software called Bayesian Labs, imputed any missing values in the training set, and let the program create the complex web you see here. Now I want to show you a real example of how our network works. So here I'm going to pull up. This is the interface for our Bayesian network currently. As you can see, there is a baseline of about 2.5% chance that a trauma patient would need blood. So looking at this first patient, you get paged from EMS. All you know, there's a 12-year-old female gunshot wound to the mid-upper esophagastric region, no obvious exit wound, active bleeding, hypotension, and waxing and waning neurostatus. So putting this into our Bayesian network, we see that there is an abdominal injury from the gunshot wound. Patient is 12 years old. It says that the patient is hypotensive. So let's say that the blood pressure is below 104. There's waxing and waning neurostatus. So let's say that it goes as low as 12 or lower. And the mechanism is from a firearm. So already we have a baseline probability of 65.7% chance of needing blood. Once the patient comes to the ED, we can then update this network. So for this patient, there was a pulse oximetry of 100 found in the ED. There was a heart rate of 90, a systolic blood pressure of 80, a temperature of 36.1 degrees Celsius, and a GCS of 14. So now we see after the patient had an initial probability of needing blood of 65%. And after this patient arrived in the ED, we were able to update our network and get a new probability of 50%. So this patient did actually receive blood. Knowing that there was over a 60% chance that this patient would need blood, before the patient even arrives to the code room, can not only alert the team to consider transfusion early on, but can be used to decide how best to prepare the room and when to remove blood from a cooler. Currently, our policy is that the level 1 rapid infuser is set up for any attending level activation. We can replace this with some threshold from this network to use our resources more deliberately and make sure that at-risk patients, even those who are non-attending level activations, have quick access to blood if they are at high risk of needing a transfusion. I just want to show you one more example. So here we have a 14-year-old female pedestrian struck at 40 miles an hour, GCS of 8, open skull fracture, right forearm deformity, and an oxygen saturation of 76% from the ED. So entering this patient back into our network, we have a 14-year-old, SpO2 less than 90% at 76, GCS of 8, head injury, and she was a pedestrian struck. Before the patient arrives, we see that there's this patient's very high risk with a probability of 66.6% of needing a transfusion. The patient shows up. They have 100% pulse ox, heart rate of 70, a systolic blood pressure of 115, a temperature of 36.7, and a GCS of 13. All of a sudden, the probability drops from an incredibly high 66.6% down to just over 8%. This shows us how flexible our network is. And with this additional information, and this patient does not actually end up receiving blood. All right. The next study I want to discuss is the Compensatory Reserve Index study, or CRI study. This is a multi-institution study we recently begun in partnership with the Children's Hospital of Colorado and Phoenix Children's Hospital. The study also focused on the early identification of patients that may be in compensated hemorrhagic shock, but using a totally different tool. Dr. Steve Moulton from Colorado Children's created this algorithm through the use of machine learning that looks at a patient's pulse oximetry waveform and continually outputs a compensatory reserve index value, or CRI value. The values range from 0 to 1 and correspond with the patient's ability to compensate for intravascular volume loss. A CRI value of 1 equates to normal volemia, while a value of 0 equates to a patient entering uncompensated shock. Values between 0 and 1 indicate the proportion of reserve remaining before hemodynamic decompensation. A lot like a fuel gauge in a car indicates the amount of fuel remaining in the tank. When a patient loses intravascular volume due to bleeding or dehydration, the tank empties and the CRI value goes down. With appropriate fluid resuscitation, the tank refills and the CRI value should go back up. There have already been several studies validating the device in controlled setting on adult resuscitations, resulting in FDA approval for adult patients. Our institution, along with Colorado and Phoenix, are now testing this device on pediatric trauma patients to validate the device and determine the sensitivity and specificity of these values. That's to say just exactly how good different cutoff points may be at identifying patients in hypovolemic shock. For this study, we have the algorithm uploaded on 2 tablets like the one you see here. The tablets connect to a patient with a simple pulse ox probe. Once connected, the tablets capture a patient's heart rate, their pulse oximetry and pulse oximetry waveforms, and they output a constantly updating CRI value. We are placing this device on all trauma patients in the code room that arrive when the device is available and when there's a research team member present to apply the device. The device is then left on patients from 4 to 24 hours, depending on the severity of the given patient's injury. We will also be conducting a thorough review of each patient's electronic medical records to determine the date and times of any recorded information or interventions that may indicate or affect the patient's intravascular volume. These include any surgical or angiographic interventions, the patient's traditional vital signs, laboratory results, imaging findings, and any fluid or medications they may have received. We're then going to align these interventions with the observed CRI values of the patients at the time to see how well they can predict or alter the CRI values. Ultimately, after validating the CRI algorithm, Dr. Moulton plans to actually incorporate this into Philips monitors, where the value can be displayed for all patients next to traditionally used vital signs like you would see here. If you're working in the emergency department, surgical care, the PICU, PACU, OR, neuroscience, or float pool, you may see this device on your patients. Our team would really appreciate it if you would please keep the device connected to the patient's finger until a specified removal time. Keep the device plugged into a power source. And if you're the one removing the device, please store it in your shift coordinator's office or the integration room if you work in the PICU. Finally, I want to discuss some broader decision support efforts that we've been working on. We're working on implementing a real-time decision support tool that can be used to assist with a wide scope of clinical goals during the resuscitation process. The simplest forms of decision support tools would rely on information being manually inputted by a provider as a resuscitation progresses. However, trauma resuscitations are usually super hectic with up to 20 people in the code room at a given time. A lot of these people are often pursuing multiple goals in parallel. This would make it, for example, as nurse left is working to obtain their manual blood pressure, the junior residents going through their primary survey, and nurse right is connecting this patient to the vital signs monitor. As with all these tasks occurring at one time, it would be pretty much impossible to ask a single person to recognize every activity going on and input them into some sort of manual decision support tool. We wanted to create a decision support tool that can accomplish the following. We need a decision support tool that can recognize and track goals as they're being pursued by the team in real time. An example of a clinical goal might be the establishment of intravenous access. We want a system that identifies and prioritizes activities associated with these goals. An activity associated with the goal of establishing IV access, maybe the application of a tourniquet or performing a flush after an IV was placed. And finally, we want a support system that recommends a plan of activities responsive to the team's goals at the right time and in a usable format. So continuing with this IV access example, imagine the team's been trying unsuccessfully to establish access for a long time in a high acuity patient. Our system would recognize the establishment of IV access to delaying care and recommend the placement of an IO instead. In order to create a decision support tool that can recognize medical activities occurring in real time, we need to start collecting as much useful data as possible on what's actually happening during the trauma. We can train a computer program to interpret the activities with the use of machine learning. To implement these complex machine learning strategies, we've been working with a team of computer scientists and computer engineers, and we've chosen to focus on 4 modalities. We are focusing on video, audio, vital signs, and an electronic checklist that we developed to be used by our team leader during the resuscitation. We installed 3 cameras in each trauma bed, one looking directly down onto the patient's bed, one looking to the bed from the back of the room, and one looking at the leadership from the front. The machine learning works by providing a training data set with various examples of activities you want the system to recognize. We create this data set by downloading videos of all of our trauma activations with consent for research use. The research team then reviews each case in a program called Mangold. The program allows the reviewer to label the start and end times of all the activities, along with attributes such as who completed the activity, was it done successfully, and was it voiced to the room. Once the video has been reviewed and a log of all the activities is created, we take these videos and feed them through our computer program. We use the log activities as our ground truth, which is to say that the computer should accept these activities as definitively occurring. And we give the program more examples. As we give the program more examples, it becomes better at recognizing these activities. Once the system is trained, we can pass other videos through and it will output the activities it believes is occurring along with a prediction score here. We can then look back on the activities our system was unsure about, the ambiguous activities, let's say, and verify if the activity is truly occurring or not. And then with the corrected predictions, we feed it back through and keep training and improving our system. We're also working on recognized activities through the use of audio with the high quality microphones in our trauma bay. And this process is very similar to the training process for video recognition. We have transcribers transcribe what's really happening and attribute those to medical activities. So in this example, we have you hear he has good peripheral pulses on the right, and then attribute that to circulation. The system is trained on these transcripts and then predicts what it believes it hears. And then to verify, we have humans go back and correct these transcripts and then feed that through again. Our teams also developed an electronic checklist application that's available on a tablet in the code room. The electronic checklist is designed to guide the team leader through the resuscitation process and allows them to take notes and check off activities as they occur. The checklist also has a section to enter any pre-arrival information and stuff from the primary and secondary survey. With the information collected from the checklist, video, audio, we create a decision support tool that can successfully recognize medical activities, and then along with the vital signs, can output recommendations. These recommendations can pop up on the checklist for the team leader or can be displayed to the entire room on a monitor like you see here. There are many possible recommendations we can provide using this technology, including alerts about delays and suggestions related to other research efforts. Ultimately, we're focused on providing real-time decision support tools to improve patient outcomes by reducing errors and promoting timely and appropriate treatment. Thank you.